You know that feeling, right? You just cannot quench your thirst. Or maybe you're always looking for a restroom.
Yeah.
We've all had that, maybe on a hot day or something. But what if that was, well, constant? That feeling of needing to drink, needing to go all the time.
Yeah, that's a really good starting point.
That's kind of where we're jumping off today to explore a condition called diabetes insipidus. DI for short.
Exactly. We're going to do a deep dive into this disorder of water metabolism.
Right.
Our mission really is to give you a solid understanding of what DI actually is. You know, the different types, what causes it, how vets figure it out.
So like a quick but thorough guide based on the info we've got.
That's the plan, based on the pasted text material provided, focusing just on diabetes insipidus.
Okay, sounds good. So let's start right at the beginning. In simple terms, what is diabetes insipidus?
Okay, so fundamentally, DI has three main characteristics. First is polyuria.
Polyuria, that's the excessive urination.
That's it, yeah. Passing a lot more urine than normal.
Huh.
Second, the urine itself is very dilute. It has a low specific gravity, low osmolality.
Ah, and that's where the insipidus part comes in.
Precisely.
Yeah.
It means tasteless. It's not like diabetes mellitus, totally different thing. That involves blood sugar, where the urine can be sweet. DI urine is, well, insipid.
Tasteless.
Okay.
And the third thing?
Polydipsia. That's the excessive thirst. It develops because the body's losing so much water through all that urination.
Gotcha. So the body's losing water like crazy, which makes you incredibly thirsty. A bit like a leaky tap, constantly needing refilling.
That's a good way to think about it.
Now, our sources mentioned there are two main types of DI. Can you break those down for us?
Sure. So you have central diabetes insipidus, CDI, and nephrogenic diabetes insipidus, NDI.
Central and nephrogenic. Okay.
The key difference is where the problem lies in the whole water regulation process.
Mm-hmm.
With CDI, central DI, the issue is a lack of antidiuretic hormone, ADH.
ADH, antidiuretic hormone. That's the one that
Yeah.
tells the kidneys to hold on to water.
Right. Exactly. It's vital for that. So if you don't make enough ADH,
The kidneys don't get the signal. They just let all the water flow out.
you got it. That's central DI in a nutshell. Now, nephrogenic DI, NDI, is different.
Okay. How so?
Well, with NDI, the body is making ADH, maybe even enough of it. The problem is the kidneys. They become resistant or insensitive to the ADH signal.
Ah, okay. So the message is being sent, but the kidneys aren't listening, basically.
Perfectly put. Even with ADH present, the kidneys just can't respond properly to concentrate the urine like they should.
That's a really clear difference. Central message problem, nephrogenic reception problem in the kidneys. And the source material links these to different body systems.
Yeah, it does. Central DI, being a hormone issue, falls under the endocrine system, hormones and metabolism.
Right.
Whereas nephrogenic DI, nephro, meaning kidney, that's primarily a renal system issue involving the kidneys and the urinary tract.
Makes sense. Now, how common are these conditions? The source said they're pretty rare.
That's right. Both CDI and NDI are considered rare. And interestingly, the source material we're looking at specifically discusses this in dogs and cats.
Ah, so focusing on pets.
Yes, though the underlying physiology is similar in mammals.
Yeah.
What's also noted is the age it shows up. Congenital forms, the ones animals are born with,
Mm-hmm.
they usually appear before the animal's a year old. But acquired forms, maybe from a tumor or an injury, or sometimes we just don't know the cause.
Idiopathic.
Exactly, idiopathic. Those can pop up at any age.
Right.
And apparently, no particular sex seems more prone to it.
Okay. So if you have a dog or cat, what are the main signs you'd notice? The red flags.
The big ones are definitely polyuria and polydipsia. That excessive peeing and drinking we mentioned, just way more than usual.
Right, the PUPD, as vets sometimes call it.
Exactly. And occasionally, because there's so much urine being produced, you might see incontinence, like accidents in the house.
Okay. Let's dig into the why a bit more. For central DI, the lack of ADH signal, what causes that?
Well, the source lists a few potential culprits. It could be congenital, a birth defect affecting ADH production.
Okay.
It could be idiopathic, meaning we can't find a specific cause. Trauma is another one, like a head injury affecting the pituitary gland area where ADH is made, released.
Ah, the control center.
Yes.
Yeah.
And finally, neoplasia, which means tumors in that same brain region, can disrupt ADH.
Right. And what about nephrogenic DI? When the kidneys are the issue, not responding, what makes them resistant?
Similar to central, you can have congenital NDI where the kidneys are just built less responsive from the start.
Okay.
But the secondary causes are really interesting. The source highlights certain drugs, actually. Things like lithium, or an antibiotic called dimethylcycline, even an anesthetic, methoxyflurane.
Wait, medications can cause this kidney resistance?
Apparently so, yeah. It's like these drugs can interfere with how the kidney cells hear the ADH signal. It's quite specific.
Wow, that's unexpected. A treatment causing another issue.
It happens. And it's not just drugs. Other underlying health problems can lead to secondary NDI too. It shows how interconnected everything is.
Like what kind of problems?
Endocrine and metabolic disorders. Things like hyperadrenocorticism, Cushing's disease.
Okay, Cushing's.
Also low potassium, which is hypokalemia. Pyometra, that's a nasty uterine infection.
Oh, right.
And high calcium levels, hypercalcemia. All of these can mess with the kidney's sensitivity to ADH.
So imbalances elsewhere can ripple out and affect the kidney's response.
Absolutely. And it doesn't stop there. Direct kidney issues can also cause secondary NDI.
Such as?
Things like kidney infections, pyelonephritis, or chronic kidney failure itself.
Yeah.
And pyometra shows up again here too, interestingly. It hits multiple systems.
Okay, so if a vet suspects DI, it sounds like there's a whole list of other things that look similar they need to check off first.
That's a huge point. Differential diagnosis is key. Many conditions cause increased urination.
Like what needs ruling out?
Well, Cushing's, again, diabetes mellitus, the sugar kind, liver problems like shunts, maybe hyperthyroidism, high calcium again, psychogenic polydipsia.
Psychogenic, so drinking too much for behavioral reasons.
Exactly, not a physical need. And of course, straightforward kidney failure. You have to rule all those out before you can confidently diagnose DI.
It really is like medical detective work.
It definitely can be.
So what tools do they use? How do they actually pin down DI?
Well, initial steps usually involve standard blood tests and a urinalysis. Just basic screening.
And what do those show in DI cases? Anything specific?
Often, they might look surprisingly normal. Sometimes, though, you might see high sodium hypernatremia because of all the water loss.
Okay.
But the key finding, especially in the urinalysis, is that persistently low urine-specific gravity.
Ah, the dilute urine.
Exactly. Typically less than 1.012, often down around a 1.08 or even lower. It just shows the kidneys aren't concentrating the urine. Normal urine would be much higher, much more concentrated.
That low number really points to that insipid quality we talked about. Very watery.
It does. Beyond those basics, measuring ADH levels in the blood can help differentiate central from nephrogenic DI.
Okay, check the hormone level itself.
Yeah. And if a pituitary tumor is suspected as the cause of central DI, then imaging like an MRI or a CT scan of the brain might be needed.
Right, to get a picture of what's going on in there.
And then there are more specific diagnostic tests.
Like the water deprivation test.
Yes, the modified water deprivation test. The source mentions a detailed protocol, which we don't have the specifics of, but the idea is you carefully restrict water under close vet supervision.
Right, you need to be careful with that.
Extremely careful. And you monitor if the urine gets more concentrated. In a healthy animal, it would. In DI, it often doesn't, or not much.
Okay. And the other one, the ADH trial.
Right, the ADH supplementation trial. This is where you give synthetic ADH, usually that drug DDAVP.
Desmopressin.
Yes. And
Yeah.
you watch to see if the drinking and urination decrease. If you see a significant drop in water intake, say around 50% within maybe 3 to 5 days, that strongly suggests central DI because you've replaced the missing hormone and it worked.
That makes logical sense. Give the missing piece, see if it fixes the puzzle. But didn't the source say something really important before doing that trial?
Absolutely critical, yes. You must rule out all those other causes of PDD first.
Right. Be sure it's not Cushing's or kidney failure or something else before you try the ADH.
Exactly. You don't want to miss the real underlying problem by just treating the symptom.
Okay. So let's say DI is confirmed. What's the management plan look like?
Well, for that water deprivation test, the animal needs to be hospitalized for close monitoring. It's quite intensive.
Right.
But the ADH trial, that can often be managed as an outpatient, with the owner giving the medication and monitoring at home.
And day-to-day? Any restrictions?
Usually no activity restriction is needed, and a normal diet is fine. The most important thing is constant, free access to fresh water. That's non-negotiable.
Makes sense, given the thirst. And owner education must be huge.
Oh, absolutely vital. Owners need clear instructions on giving meds, especially DDAVP, the dose, how to give it, and stressing again and again the need for water access. Dehydration is a real risk otherwise.
Okay, let's talk about the specific medications. For central DI, what's the treatment?
For CDI, the main treatment is replacing that missing hormone with DDAVP, the synthetic ADH.
Right. How's that given?
There are a few ways. There's an intranasal liquid form. You can put like 1 or 2 drops into the conjunctival sac of the eye.
Into the eyelid pocket.
Exactly. Usually every 12 or 24 hours.
Right.
That helps control the symptoms. Or that same liquid can sometimes be given as an injection under the skin, subcutaneous.
Okay.
The dose there is usually 2 to 5 micrograms, again, maybe every 12 to 24 hours. And there are oral tablets too.
Tablets seem maybe easier.
Can be. The source notes that roughly 1 big drop of the nasal stuff is about equivalent to a 0.1 milligram tablet. So there's some flexibility there.
Good to have options. Now, what about nephrogenic DI? Where the kidneys are resistant, giving DDAVP won't work then, will it?
Nope, exactly. Since the kidneys aren't listening to ADH anyway, giving more doesn't help. The strategy has to be different.
So what do they use?
The main drug mentioned is hydrochlorothiazide. It's actually a diuretic, a water pill.
Wait, a diuretic for a condition causing too much urination? That sounds backwards.
I know, it seems counterintuitive. But in some cases of NDI, these thiazide diuretics can paradoxically reduce urine output. It's a specific effect in this context.
Okay, so the doses...
The source gives a typical dose of 2 to 4 milligrams per kilogram of body weight, orally, every 12 hours. It really shows how different the approach is for NDI versus CDI.
Definitely different strategies. Are there any big warnings or contraindications for these meds?
Interestingly, the source we have says no specific contraindications are listed. But, and this is a big but, with DDADP for central DI, overdose is a serious risk. Giving too much can lead to water intoxication.
Water intoxication, like too much water retention.
Exactly. And that can be dangerous, even life-threatening. So sticking to the prescribed dose is absolutely critical.
Wow, okay. Good to know. So once treatment starts, how is the pet monitored?
Mostly by watching their clinical signs. Especially for central DI treated with DDAVP, you adjust the dose based on how much water the animal is drinking.
So watching the thirst level.
Yeah. The source suggests routine blood tests just to check for dehydration usually aren't needed because owners can typically monitor the thirst and urination pretty well at home.
Okay. And can DI be prevented, or what about long-term complications?
Well, you can't really prevent the congenital forms. For acquired types, maybe avoiding things that cause significant water loss is good practice generally. Complications often relate to whatever caused the DI in the first place.
Like if it was a pituitary tumor causing CDI.
Exactly. The tumor itself might cause other problems down the line as it grows.
So what's the overall outlook, the prognosis for pets with DI?
Generally, the source says the condition is permanent, unless it was caused by something temporary like trauma, which is rare.
Okay, so usually lifelong management.
Usually. But the prognosis itself is often good if the underlying cause can be managed and the treatment is consistent.
But untreated?
Well, untreated DI is very serious. Severe dehydration can lead to lethargy, confusion, eventually coma, and even death. So diagnosis and treatment are vital.
That really drives home the importance of getting it figured out and managed properly. Okay, so let's quickly recap this deep dive. Diabetes insipidus, it's all about water balance going wrong. Too much thirst, too much dilute urine, either because the ADH hormone signal is missing, that's central DI,
Right.
or because the kidneys aren't responding to the signal, that's nephrogenic DI.
You got it.
We talked about the causes: congenital, trauma, tumors, even some drugs or other diseases, and how vets diagnose it, ruling other things out using tests like water deprivation or the ADH trial.
And the different treatments, DDAVP for central, hydrochlorothiazide, often for nephrogenic.
Exactly. It really highlights how delicate that whole water regulation system is.
It really does. You need that thorough workup to know why it's happening to choose the right treatment. It's key for their quality of life.
Absolutely. You know, diving into DI like this, it really makes you appreciate how finely tuned everything is. If messing with ADH or kidney sensitivity has such big effects, well, makes you wonder, doesn't it? What other small, seemingly minor disruptions in our body's complex systems could have really significant, maybe surprising impacts on our overall health down the road?
That's a great question. Definitely food for thought.